Malu di sudah nak tahu kan? Jadi company. Kau itu na? Eh? Ya, ini sih. Lama ya. Kita हो packing क्या है वही एग्जाम आवाज से एग्जाम ऑगस्ट आके देखियो 14 ऑगस्ट एग्जाम आवाज से ત્યારે એટલે બધું થોડું રાખાય છે થોડા કપડાનું બાકી બધું મોસ્ટલી ખાલી છે
Contina. Monar. Well, good evening, everyone. Am I audible? Dr. Hemant?
Yeah, I'm audible. Yes,
All
yes,
right.
you're
Yes, yes.
audible.
So, a very
Right.
good evening to
Right.
all, and I welcome my very good and my old friend, Dr. Hemant Kumar Kar, former Director and Dean of Medical Superintendent and Head of Department of Dermatology, PGI MER Association, Associated RML Hospital, New Delhi. And he was former Dean, Schools of Medicine, CGSI, IP University, Delhi. He was former Professor of Dermatology, NDMC Medical College, Delhi, and he was past President of IADVL Delhi chapter, past Vice President of IADVL. He was past President of Indian Association of Leprologists, past President of IASTD. He was Counselor IAL, and he has written probably one of the best book on dermatology. On leprosy. That is IAL, Indian Association of Leprology textbook of leprosy. And because of that only, I kept this background image of Mahatma Gandhi, who was looking after probably the lepra bacilli in the microscope, and this picture, this was inspired by this book of IAL textbook of leprosy. So he has authored many chapters in several medicine, dermatology, STD, and leprosy books, and he has got 131 research publication in index and national international journals. Chairman of Leprosy Research, ICMR, and Chairman of SSC, Jalma Agra. He is a very knowledgeable person. Recipient of IADVL Glaxo Oration Award, Teacher Par Excellence Award, and Indu Bala Memorial Award for contact dermatitis also. Professor Kandhari Award, Delhi Chapter IADVL, and Oration Award in 2018, and is an International Scientific Task Force expert member for chemoprophylaxis research and leprosy. So now today, probably is one of the most knowledgeable faculty with us, and he will tell us all the postgraduates and the other people, senior people, those who are attending this webinar, the recent advance in the management and treatment. So everything, all is yours. And Dr. Hemant, when you will speak, we will change the slides from here. I am sharing the screen. Shall I start sharing the screen and showing the slides?
Yeah. Thank you. Thank you, Professor Dinesh Mathur, my very close friend. And I'm very grateful you have given me this opportunity to discuss with our postgraduate students. Good evening to everybody, to my dear postgraduate students and my colleagues, all are watching. Let's start the first slide.
Almost 90 people are here.
Okay, that's good. That's good.
I'm starting the screen.
Yeah. Right. Yeah. Can I make it? Okay, I'll make it larger.
Yes. Is it all right now?
Okay. Thank you. That's good. So my topic is today on discussion on the update on treatment of leprosy. So far, what we achieved and what we should achieve in future. Let me go to the next slide, please. Next slide, please. Can you change the slide, please? Okay. So if you look into the medical management of leprosy in practice right from 1960 to 97, there's a lot of evolution of treatment in leprosy. Next, please. Next, please. Next, please. Next, please. So if you look into the from 1960, 1960 to 1980, only dapsone monotherapy was the, go to the back, go back, please. Go back, please. Go back, please. Go back, please. Yes, please keep it able. Yeah. Go back. Next. Yeah. So if you look at the evolution of treatment of leprosy, we start dapsone monotherapy in 1960 to 80. The only monotherapy was going on, and for multivessel leprosy, we used to give dapsone for a lifelong. And what happens during that 20 years, a lot of dapsone resistance develops because of the monotherapy. So the WHO conducted several trials how to take care of this dapsone resistance. So they introduced the multi-drug therapy. After several trials, trials went on for about 10 to 15 years. Then the first time, 1981, WHO MDT medicine was started. Initially, they give for 3 weeks intensive therapy of 3 drugs, dapsone, clofazimine, and inflammation, and then changed to 14 days intensive therapy. It continued. So finally, sorry. And in 1983, the WHO MDT was started, which was backed by the Indian Association of Leprosy and National Leprosy Eradication Program. And those intensive therapy daily regimen was stopped. They found in different trials by giving this intensive 21 days or 14 days therapy, it does not help much. So finally, it was approved by the WHO to start only 24 months multi-drug therapy. And later on, in 1997, this 24 months has reduced to 12 months for multivessel leprosy and 6 months for pervasive leprosy. And then finally, from 2018, WHO uniform MDT in the subsequent slides. Next slide, please. Next slide, please. So if you look into WHO multi-drug therapy, what we are using nowadays, it consisting of 3 drugs, rifamycin, dapsone, and clofazimine, which comprises MDT. And these all 3 drugs we are giving for the multivessel leprosy, and the 2 drugs, that is rifamycin and dapsone, 2 drugs we are giving for pervasive leprosy or bacteriologically negative cases for 6 months. And clofazimine has an additional anti-inflammatory effect that we'll discuss later on. Next, please. Next, please. So if you look at the dosing schedule of MDT, the standard adult regimen for MB leprosy is rifamycin 600 mg once a month, along with clofazimine 300 mg once a month, and then daily regimen of 50 mg of clofazimine and dapsone 100 mg, and total duration of 12 months. And the standard adult treatment for PB leprosy, rifamycin 600 mg once a month, dapsone 100 mg daily, and the duration is 6 months. And you should be very much acquainted with the blister packs available. Next slide, please. The blister pack available, you can see here, the green color is pervasive adult blister pack, and the pink color is MB adult blister pack. If you see the top of the blister pack, that's the regimen monthly. Once you have to give supervised, and in the 2 rifamycin capsules are available, 1 dapsone in the pervasive cases, and in multivessel cases you'll find 3 clofazimine 100 mg each, 300 mg of clofazimine, and 2 capsules of rifamycin consisting of 300 mg each, total 600 mg, and dapsone 100 mg. These 2, you have to give the medicine to the supervised treatment, and the rest of the packs he has to take away to his home to continue unsupervised. And my dear postgraduate students, you must see these blister packs, and because in oral examination, these types of blisters packs will be available, and they will ask you to speak something about these packs. Then color is also very important. See, the PB color is green for a multi PB pack, and for the MB adult, the color is pink. Next, please. Next slide, please. In the next slide, you will see the MDT in children. The dose has been reduced from 10 to 14 years. Rifamycin 450 mg, clofazimine 150 mg once a month, and 50 mg every alternate day. Dapsone 50 mg. Duration is 12 months for MB, and for PB, rifamycin is 450 mg instead of 600 mg once a month. Dapsone 50 mg only, and the duration is 6 months. You must see the color of the blisters. Next slide, please. Next slide, please. See the color of the PB child blister pack, blue color, and the other one is the brown color. Now let's discuss about the dapsone which is the main drug which has been used since past. Next, please go back. It inhibits the synthesis. No, next, please. Next, please. Next one. Next slide, please. Yes, please keep it. So the dapsone is the very weakly bactericidal drugs, and we must all aware of the adverse effect of the dapsone is very, very important, because it is very rarely it produces hemolytic anemia when there is G6 deficiency. So in hospital based, you can do the G6 level before starting dapsone, though we don't do normally in our programs. It very rarely produces agranulocytosis. The most important is dapsone hypersensitivity syndrome. It comes as a short note in a leprosy paper. So you must be very much acquainted with dapsone. You must have seen in your hospital rare cases, though it occurs rarely, but sometimes it becomes fatal. It starts with fever, skin rash, progressing to erythematous papules, pustules, and plaques. It leads to exfoliated dermatitis, generalized lymphadenopathy, hepatitis, hepatosplenomegaly. It also produces hemolytic anemia, and it involves the lungs producing eosinophilic pneumonia, pleural effusion, and this very, very important fatal. A patient has to be admitted in the hospital and was treated with steroid, and you have to maintain the electrolyte balance, and it is the fatality rate is of 5 to 10%, just like other drug hypersensitivity syndrome. Next slide, please. Reformation is the most important drug. It is highly bactericidal. It inhibits the DNA-dependent RNA synthesis, blocking the RNA polymerase, and it admission monthly once because of its slow growth. Very important. Our Leprosy grows very slowly. It divides in every 14 days. So when we give reformation monthly once, it's quite sufficient to kill almost like a single dose in every month. Next slide, please. Next is clofazimine. Can you next slide, please? The adverse effects of reformation is minimal side effects. It only except the changes in the color of the urine and tear become red and orange, and rest adverse reactions occurs when given weekly, 2 to 3 times daily, particularly when give just like DOTS regimen in tuberculosis. But fortunately, in leprosy, since we are giving this drug monthly once, these syndromes like flu-like syndrome, renal failure, thrombocytopenia are very, very rare when you give monthly dose leprosy, this reformation to our leprosy patients. Next, please. Next. Regarding clofazimine, it is a dye, particularly it is immunophenazine dye. It is weakly bactericidal. It has also mild immunosuppressive effect. That's why it is given in type 2 reactions. And the monthly supervised dose helps to maintain a therapeutic effect. Because why we give clofazimine monthly once in addition daily? Because once you give it produces cumulative effect. It gets deposited in the body fat. Next one. So next, please go ahead. Adverse effects of clofazimine, nothing except the discoloration of the skin, and the most important is this multi-drug therapy what we give. It's quite safe in pregnancy. Even though the patient gets pregnant, you can continue the treatment. The other useful drugs, which is next slide, please. Other newer compounds we'll discuss one by one. Stand by useful compounds for used for leprosy treatment. Next, please. Next. Yeah, the first is fluoroquinolones. It consists under that fluoroquinolones we have drugs like ofloxacin, pifloxacin, sparfloxacin, and moxifloxacin. Next, the next is enzymation group. Next slide, please. Tetracycline group, minocycline is the next drug. Next, please. Next is macrolides. There's a clarithromycin. These are the drugs. Next is enzymation group, that is reformation group, the derivatives of other two rifabutin and rifapentin. Next is next one. Please go ahead. Dihydrofolase reductase, diaroquinolone, bedaquinolone, desoxyfructosyrettase, beta-lactam resistance antibiotics like cephalosporin, cephalosporin, and fusidic acid. And all these drugs we have with us in our pocket for future use. And in case of, these are all second-line drugs we kept ready whenever. Next slide, please. Next slide, please. Next. We will discuss one by one in the subsequent slides. If you ask, do we need alternate chemotherapeutic agents in leprosy? Yes, we need, and there are certain situations. Next slide, please. For patients with drug resistance, whenever the patient develops, because nowadays adaptation and reformation and ofloxacin resistance are coming up, so that's why we have to keep these second line drugs for use in case of drug resistance, and it could be single or multiple drugs, and also for drug allergy and intolerance. Next, please. Next. And the dapsone and clofazimine weakly bactericidal, basically they're bacteriostatic drugs. So we need replacement whenever we need to reduce the duration of therapy. Next, please. Next, please. So the deadly component dapsone and clofazimine could not be supervised in we should have a good regimen having all three bactericidal drugs so that we can next we can reduce the duration of therapy and we can give it supervised. Next slide, please. So we have to use all the highly bactericidal drugs may help in shortening the duration of therapy and could be administered in a supervised way monthly once. Next, next, please. So if you look into the comparative bactericidal activity of these newer anti-leprosy drugs, next, please. Please go ahead. Next slide. Next. If you see this, this is a very good, very important slide. See the rifapentin, the metabolites of rifamycin. It is really highly bactericidal. Rifapentin and moxifloxacin, they are highly bactericidal, not only in the mice but also the human beings. These two drugs, and along the fluoroquinolones, other drugs like pfloxacin, ofloxacin, clarithromycin, minocycline, they are all moderately bactericidal, both in mice and drugs. And normally, these 6 drugs we should keep ready for if we want to change the drug, if we need required to use the second line drugs. Next, please. Next, please. So we'll discuss this ofloxacin. As you know, this has been used for a long time in Rome regimen. Rome means rifamycin and ofloxacin and minocycline. And this minocycline and other is moxifloxacin. We'll discuss one by one. This minocycline, it has been used by the dermatologist very often for other conditions like particular acne. It is strongly bactericidal. It is a lipophilic, easily enters the bacteria, binds to the 30S ribosomal units, inhibits the protein synthesis and produces death of the organism. And if the mouth property nucleation studies shows it killed all bacteria in 4-week treatment. That shows how bactericidal activity this minocycline has when you give orally 100 mg daily, or if you give monthly regimen 200 mg as part of the supervised regimen, including other bactericidal drugs like rifamycin and moxifloxacin, it will be very effective. The side effects of minocycline is very minimal. It produces only nausea, diarrhea, dizziness, mouth sore, and of course it produces discoloration in teeth. Therefore, my children. Next, please. Next slide. Next slide, please. If you look at the clarithromycin, this is also a very good drug. It kills leprosy by inhibiting the protein synthesis by binding with 15 ribosomal units. You see the minocycline acts at the 30s ribosomal unit. So when we combine clarithromycin and minocycline, it produces a synergism where because of their sequential action in the inhibiting the protein synthesis. And see, if you give 28 days regimen, it can kill almost 99% of the bacteria, and you extend it up to 56 days, that in 8 weeks, it kills 99.99 viable bacilli. So the combination of clarithromycin and minocycline is very good. Another advantage of clarithromycin is this: it can be given in the children. In all age groups, clarithromycin is acceptable to the children, unlike the moxifloxacin and the minocycline. Next slide, please. Next, please. Next slide, please. So the side effects is very minimal. GI problems because it's a macrolide. Some have, otherwise it is very effective. Regarding ansamycin group, I told you rifampicin and rifabutin, they're two drugs, very good drugs. They're all found more effective than parent drug, that is rifamycin. And these two drugs, and the MIC value of this drug also very less than rifamycin. But the problem is the future role of these compounds may be limited. Once the patient develops resistance to rifamycin, then to use rifampicin and rifabutin will be very difficult because of development of cross resistance, though they are better effective than rifamycin. And another important problem is it is very high cost. So it is very difficult, this type of costly tablets, to introduce in our leprosy eradication program. And also rifabutin produces very severe side effects. So probably rifamycin is still better. Rifamycin, we can continue rifamycin along with other two and bactericidal drugs. Next, please. The fusidic acid we have been using as a local ointment, antibacterial ointment, but in tablet form, it is available in 500 milligrams, 750 milligrams, and when it is given in, it can kill 99.5% of viable bacilli within in both regimens, 500 milligram and 750 milligram. It also has immunosuppressive activity. When it is given with rifamycin, it has an additive and a synergistic action. So this fusidic, but unfortunately we have been using this locally. So the resistance part we have to see before using this drug. And in fact, this drug is not available in tablet form nowadays. Next, please. Next. Next. The new dihydrofolate reductase inhibitors, most important I must tell about brodimoprin and K30. It's a derivative of the trimethoprim, sulfonyl groups, and it has been found easily penetrate bacterial cell wall and blocks the second step of folate synthesis. Both of the mice, as expected, these drugs has been a synergy with the dapsone. It can be combined with dapsone also. And this is a good drug. This particularly, it should be kept in reserve for future. That is brodimoprin. Next, please. Next. Next slide, please. Next slide. Can I have the next slide, please? Yes. This has been, there is a small study combining 200 milligram of brodimoprin with 25 milligram of dapsone and 60 milligram of rifamycin daily for 3 months. It has given excellent clinical result, but unfortunately, the full trial result is yet to come to give you the knowledge, but it's long back it is in tried. I don't know why the final result never published. Next, please. Next. Bedaquiline is a diaryl quinolone. Is also a very good drug, has a high bactericidal activity. it affects the proton pump of the ATP synthetase, thus disrupting the bacterial energy metabolism. Like clofazimine, it also persists for a long time in the tissue, and but of course, unfortunately, it has side effects like arrhythmias and prolonged QT intervals, cardiac problems. It has never, it was not tried for use in leprosy. Although it has a very good bactericidal activity equivalent to that of rifamycin and moxifloxacin. Next, please. Next. So now the question that come Rome. Rome, that which combination of rifamycin, ofloxacin, and minocycline has been used for last 30 years, and 20 years back this regimen was authorized. Later on, the Bangladesh trial shows a lot of relapse, 3.6% relapse, and we do not know. The ultimately WHO as well as National Leprosy Eradication Program removed this Rome regimen for single dose for single leprosy. But it has been used by WHO. The trial was conducted Rome 24 months monthly pulse trial, 12 months and 24 months, and 3 months for possible slurry, 6 months for possible slurry. The initial results show very good, but I don't know. It has been tried in 3 countries, Senegal and Guyana and Myanmar. Unfortunately, the final result never came from WHO. Next, please. However, this Rome regimen tried into other 2 different countries like Philippines. Next slide, please. Philippines and also in Brazil. And this is the initial chemotherapy result of 4 regimen trial. It has been done by WHO to see the comparable effect of 12 doses, 24 doses of normal MDT, and a very short course therapy that is called the RO trial, combination of rifamycin and ofloxacin only for 28 days, and the 4th hand is MDT for 24. There are 4 hands. They tried it, and unfortunately, we have find all the MDT regimen, 12 months regimen, 24 months regimen, and addition of ofloxacin in the first 28 days to MDT 12 dose regimen all worked very well, but unfortunately the short course therapy of RO, rifamycin and ofloxacin 28 days, a lot of relapse occurs after the 5 years. Therefore, it was not beneficial. It was stopped this RO short course regimen. This regimen was also been tried by Brazil. Next slide, please. By other countries also. In the Brazil group also, Cebu, Philippines, this trial was going on, and they found, particularly in PB leprosy, this combination was very good. Combination of ofloxacin and rifamycin for 4 weeks. They tried to compare with the 6 months course of WHO MDT regimen in PB, and they found the relapse is almost similar in both groups. So probably this combination, rifamycin and ofloxacin for 1 month, would have been can be used in possible cases. Next slide, please. This was tried in the Philippines. Next, please. So the Philippines also they tried in multi-vessel leprosy, 1 year regimen, 2 years regimen, 1 month regimen, same the what the WHO has made it, and they found the similar result. But in the Brazil group also for 12 years regimen, 24 months regimen of WHO, it gives the similar result. There is no extra benefit giving MDT for another 12 months. However, this short course 1 month daily dose of rifamycin ofloxacin was never successful in any type of leprosy except PB. Next, please. Next slide, please. Next, please. So they found in all 3 regimens with WHO MDT, relapse rate is almost equal to 3%. However, with regimen 3, that is combination of reformation of fluctuation relapse. So relapse occurred late, beginning at 5 years after initiation of therapy, confined to BL and polar LL. Therefore, this short course therapy combination of reformation of fluctuation was a failure, and it was never used in future. So this you must be knowing the bacillary leprosy. When the bacilli multiplies very slowly, the short course 1 month regimen will never be applicable. Whatever bactericidal drugs you combine with that, so therefore uh, minimum 6 months to 12 months course is 12 months course is required when you are dealing with multivesicular leprosy, either monthly pulse or daily regimen. Next, please. Next, please. Next one. This is a very same thing. Brazil trial, same regimen, 4 hands, 12 months MDT, 24 months MDT, and 28 RO regimen. Additional ofloxacin to 12 days to 4 milligram daily for 28 days to WHO regimen. All the 4 arms separately, the same regimen what WHO conducted. Brazil people also conducted this study. Next, please. And they also find the similar result. 12 months regimen, 24 months regimens, addition of ofloxacin to 12 months regimen, all three gives the equal result. However, the RO regimen never gave good result. Lot of failure, lot of relapse in that short course 28 days RO regimen. Next, please. Next slide, please. Now the most important is uniform MDT regimen for all tissue leprosy. That was the latest regimen trial by WHO, started in 2008, completed in 2015 in several countries, including India, China, Bangladesh, and also Brazil. Next slide, please. And separately also it is tried by different people, including Dr. Rao also. This is the international open trial of uniform immunity regimen for leprosy patients and the finding and implication for national leprosy program. It was reported by Indian Journal of Medical Research. This study of India, China, and Brazil, though Brazil published separately, and this is the publication of by ICMR, combination of India and China trial. There are a lot of people, the study sample was very huge, more than 2,000 in PV cases, more than 1,200 in case of MB cases. And the primary objective was to determine acceptability, safety, and compliance. Next slide, please. Because these 3 drugs are giving both persuasive and multivesicular. So in PB cases, when you're giving clofazimine, there is chance of always discretion there, whether it was accepted well or not. That was one of the objective of this trial. And among the PB and among the MB, the relapse rate is very less. Even it is given, all 3 drugs was given for 6 months, and the reaction, type 1 reaction pattern, type 2 reaction, 1 pattern also almost similar type. And next slide, please. Next slide, please. This is the WHO trial was combination of, and conclusion, they found the conclusion, even to give 6 months treatment of uniform MDT, the minimal adverse drug reaction, no relapse, accepted clofazimine related pigmentation was good among the PV patients. All above supports the introduction of UMDT in national program 6 months regimen. This is the conclusion by the um, by the India and China group. Next is Brazil group. Next slide, please. Next slide. The Brazil group also they published separately the same protocol. Next slide, please. Next slide. Next slide, please. Next. They also give the similar conclusion. Our results on the first randomized control study on UMDT together with the region from 3 previous studies performed in China, India, and Bangladesh supports the hypothesis of UMDT is an acceptable option to be adopted in endemic countries to treat leprosy in the field condition for 6 months duration. And next, then WHO people shared together. Next slide, please. After they analyzed the data of all 4 countries, this is the summary of the Brazil trial. This study supports among the MD leprosy patients treated with regular and MDT with uniform UMDT regarding frequency of leprosy reaction and disability progression, relapse. Overall, their results showed that it is quite effective, just like the report from India, China, and Brazil. UMDT can be considered as part of the leprosy policy by control program in endemic countries. Next slide. Next slide, please. And when this guideline was prepared by the WHO, our Indian Association of Dermatologists, Leprosy also, we had a lot of objection regarding use of the 6 months course in multivessel leprosy because of the follow-up period in all those trials, Brazil, China, and India. The follow-up is too less to really conclude the 6 months MDT will be effective in multivessel leprosy, particularly where BI is very high. So ultimately, the experts all over the world, they sat to prepare the guideline, diagnosis, treatment, prevention leprosy in 2018, and our IADVL also presented our statement to WHO also. It is too early to reduce the duration of therapy from 12 months to 6 months, particularly dermatologists, all the dermatologists of the country who treat the leprosy patients maximum in this country, they didn't never agree the 6 month therapy. We have to wait. We have to do the follow-up, all these studies to really conclude really the 6 months therapy is sufficient or not. So finally, the WHO agreed to our proposal. Next slide, please. And ultimately, the final report came like this: 3 drugs regimen compromising reformation, dapsone and clofazimine for all leprosy patients with a duration of treatment lasting for 6 months for possibly. Finally, they agreed, yes, for multivessel cases, we should continue 12 months treatment, all 3 drugs. However, in PB leprosy, they added the clofazimine. It's always good. Addition of 3rd drug in PB is always good. Why it is good? Sometimes there is a misclassification of leprosy, whether it is a possibly or multivessel. In that case, at least we are giving 3 drugs for 6 months, and it's quite good enough to prevent relapses. Next slide, please. So advantage of using this same regimen, most is simplification of the treatment. The same blister pack, I have shown you the blisters, different blisters, 2 drugs regimen blister, 3 drugs regimen blister. At least now the same blister can be used by our workers, leprosy workers, and also reduce the impact of misclassification of MB and PB, since all will get 3 drugs regimen at least. At least they will get 6 months regimen, all the 3 drugs. And this will definitely, combination of 3 drugs prevents the further drug resistance in future. Next, please. Next. Why the 6 months regimen for MD was not recommended by WHO, that I will explain to you. The evidence on potential benefit and harm of 6 months course was limited and inconclusive, with a potential risk of relapse to support those 6 months MDT for MD regimens. That is why it was discarded, and ultimately WHO came out with what our IDVL reported this study. Next, please. Next, please. Next slide, please. There are different special situations where we have to modify our regimen, and this is the latest WHO guideline 2018. Next slide, please. In case of reformation resistance or reformation allergy or chronic hepatitis, which sometimes reformation rarely produces, the regimen is like that. For multivessel patients, clofazimine 50 milligram plus at least 2 second-line drugs, quinolone among the fluoroquinolones, either ofloxacin or moxifloxacin 4 milligram each, or minocycline 100 milligram, or clarithromycin. We have all 4 drugs available. Out of these 4, you have to select 2 second-line drugs for the first 6 months, and then followed by same clofazimine with anyone as above for 18 months. This is the latest recommendation of WHO in case of rifamycin resistance, single rifamycin resistance, or rifamycin allergy, or patient develop chronic hepatitis. In that case, in place of rifamycin, we give the combination of clofazimine and 3 drugs. Ofloxacin is good, moxil is costly, so you can opt for ofloxacin, and you can give minocycline also. And I have already told you the minocycline plus clarithromycin has very good synergistic effect, so you can use that. When you develop resistance to both rifamycin and ofloxacin, in that case, you cannot give any drug from fluoroquinolone groups, either ofloxacin or moxifloxacin, and the best combination will be clarithromycin plus minocycline plus clofazimine for the first 6 months. Clarithromycin is 500 milligram, minocycline 100 milligram, clofazimine is 50 milligram, and the other one, then can you go to the back? First 6 months, 3 drugs, then next subsequent 18 months, 2 drugs, followed by clarithromycin or minocycline plus clofazimine for 18 months. This is very all postgraduate students. Please remember this thing when a in case of resistance to both rifamycin and ofloxacin. Please never start these drugs without conferring this resistance to rifamycin and ofloxacin. As you know, nowadays the biological molecular level techniques are used to find out the resistance, all 3 drugs, and you can get the report within 7 days. The program has established 5 different regional centers. You can send the samples, skin biopsy sample, to these 5 centers. You can see the website of the National Leprosy Eradication Program. You will find all the 5 sites, regional sites, whichever is nearer to you. You can send the skin biopsy sample to them, and you'll get the result within 7 days. Without getting the result, don't try to use these second-line drugs. When the report comes, whether it is resistance to rifamycin only or resistance to both rifamycin and ofloxacin, because they do the resistance study for all 3 together, dapsone, rifamycin, ofloxacin. After getting the result, you can use these drugs. Next slide, please. Whenever there is clofazimine is non-acceptable because of the color, in place of clofazimine, you can use ofloxacin 4 milligram or minocycline 100 milligram as a substitute to CLF, or the Rome regimen we have discussed earlier. This Rome monthly regimen you can use for monthly for 24 months. And the Rome regimen is really very good. It's not very costly. You are giving only monthly once for 24 months, and the efficacy is almost similar. Final result of this Rome monthly 124 months regimen, they have used 12 months and 24 months. Since we have not got result, so we have written 24 months. In cases dapsone toxicity, as I told you, dapsone is very weakly bacteriostatic, is a bacteriostatic drug. So if you are not giving dapsone, you can use combination of only clofazimine and rifamycin for 12 months in case of MB, and in case of PB, instead of dapsone, you can use clofazimine and rifamycin. Next slide, please. Some moxifloxacin based regimen, it's a very good drug, almost equivalent to rifamycin. Moxifloxacin alone was proved to be highly effective in MB patients. In a combination of moxifloxacin, rifampicin, and minocycline, probably this is the best combination so far as all new drugs are concerned. It has been recommended for human trial by Dr. G and Dr. Crochet during Asian Leprosy Congress, Agra, and also it was suggested in our pre-Congress workshop of the International Leprosy Congress held in Hyderabad in 2008. But unfortunately, this 3 drugs trial has never been done. However, in Bombay, next slide, please. Next slide, please. Fluoxetine has been used along with the rifamycin and minocycline monthly once. Next slide, please. Ofloxacin, sorry, moxifloxacin and rifamycin and yeah, it has come. Ganapati in 2009 tried this combination rifamycin, oxyfloxacin and minocycline combination, minocycline positive MBPS and there's no side effects and mild ENL, and the Dr. Pai is following those cases only. The follow-up is very important to see the relapse rate, because any type of combination, the best objective of this study to see the relapse rate. So unless you follow 5 to 10 years, you never know whether this regimen is effective or not. So let's wait for Dr. Pai. I was personally asked Dr. Pai to publish the result very soon to really get this 3 combination supervised treatment. This is one advantage of this therapy is supervised. Patient will come monthly once, and in front of you, the patient will take all the 3 medicines, and you are ensured the compliance of the drug therapy. They have given for 12 months, and the follow-up result of this study will show how effective this combination is. Next slide, please. Next slide, please. So the goal of our future regimen is we should have a well-tolerated regimen with minimal adverse effect. It should be highly bactericidal. We can remove dapsone and clofazimine very well. If you get 3 bactericidal drugs, we can give supervised way so that we can minimize the non-compliance. And we should have a regimen which can suppress the leprosy reactions in order to minimize the complications. And the final, the most important is acceptable cost. Because cost of these newer drugs are very high. If you could able to give it monthly 12 doses of these 3 combination, it may not be very costly. Next, please. So our take-home message for the WHO regimen is still the main therapy with the capability of eradication of leprosy from the globe. The newer, highly bactericidal drugs we discussed is a great promise, should be reserved for multi-drug resistance cases. Never try these secondary drugs unless you confirm the resistance to rifamycin, dapsone, and ofloxacin. Indiscriminate use of these alternate drugs for leprosy must be discouraged. Evidence on potential benefit and harm of these drugs are not available. Very important. Chemotherapy does not reduce the nerve damage. You know very well. Once nerve is damaged, this chemotherapy will not help it. Therefore, the diagnosis, early diagnosis is very important. Before the nerve damage occurs, before nerve involvement occurs, if you start the material therapy, it may prevent nerve damage. Therefore, these are very, very important things. Another trial I just forgot to include it. There's a trial by PGI at Chandigarh. Some non-responding leprosy, you can try this combination of drugs, Rome regimen, the rifamycin, ofloxacin, and minocycline. They have tried in 35 patients, and they gave a very good encouraging report. It was published last year, 2009, and it gives very encouraging result. So there is a lot of good bacteriological fall. So in case of recalcitrant leprosy cases, suppose you are working in the field, you are not able to send the skin biopsy for resistance study. This combination Rome regimen you can give for 24 months, and it's really very effective. The PGI Chandigarh report shows it's very effective, the Rome regimen, if you give regularly for 24 months. With this, next slide, please. I think it is the last slide. Any clarification in the discussion we can have? Person Mathur, please. Dr. Dinesh.
Yes. Now we have got several questions. I'll be
yeah.
those questions to you. Since
I
there were
think
some
that will be very nice.
options.
Yeah,
Well, it was a very nice lecture, Dr. Hemant. We all enjoyed, and people also enjoyed a lot, and there were almost more than at the time 141 participants, and they have raised several questions. Uh,
Yeah, please.
more of them were because of the audio problem, and audio problem is depends upon the internet issues, internet at the
Uh,
local places. So there
they
no
can
nobody can
write
help.
and
Sometimes it happens. But anyway,
what is the, I got some, sir. What is the efficacy of reformation preventive to contact now used in program? Yeah, that's a good question by somebody from Galaxy.
I'll,
Reformation that is called
Hemant,
single
Hemant,
dose therapy, single
Hemant,
dose. Yeah, please.
let me
Yes,
ask.
please.
Dr. Shahnawaz asked that is there any role of deoxyfructose serotonin rich therapy, and if we can promote this as an adjuvant treatment?
Yeah,
Deoxy.
no, yeah. Yeah, this was a drug used long back, and nowadays there is no further trial of this drug. That's why there is no need to discuss about this drug. But this is, if required in future, we have other good antibacterial drugs available for us. So that's why this serotonin has not been used nowadays. And even no trial has been done also on this drug.
Dr. Bhavya, she asked that possibility definition, according to new WHO definition, does not include number of nerve involvement, while
Yeah, this.
multivariate type mentions about the neuritis. Does that mean all cases with clinical or subclinical neuritis need treatment with MB-MDT, or only clinical neuritis cases?
Yeah, the definition of possible leprosy has been changed from time to time. You know,
Yes.
earlier it was there five skin lesions, five lesions, including one nerve lesion with bacteriological negativity is very, very important now, since they nobody is doing mouth that all is there, because any type of bacteriological positivity, even it is a single lesion, it should be considered as multi. If you do the skin screen examination, you find bacteriologically positivity, you treat the case as multivessel leprosy.
And Ramesh wanted to ask treatment during lepromatous reaction.
Hey,
Probably,
Ramesh now I know.
Yeah. Hello.
yes.
Yeah, any type of reaction, multi treatments must not be stopped. That is very, very important. That the standard mandatory by WHO, never stop the multivessel MDT during the reaction. You treat the reaction with the drugs in the state, but never stop the multi-drug therapy.
What should be the treatment approach? Dr. Bhavya asked, what should be the treatment approach for rifampicin resistance for children, as fluoroquinolones and tetracyclines cannot be
Uh,
used in children, especially less than 8 years of age?
Yes, this is a very good question. The best regimen for children is you can give clarithromycin and clarithromycin, and you can give clofazimine, and because propranolones we cannot give in a, so the minocycline you cannot give. You can give the regimen of clarithromycin, dapsone, and clofazimine. And I must tell you another point, the fluoroquinolone groups, European Physicians Association, they have sent a warning not to use fluoroquinolones in future, very because they have found the tendon rupture and tendinitis very often they found in European countries when they're using fluoroquinolone groups. So they have a warning. Try to they discourage to use the fluoroquinolone no more in future. But since fortunately either moxifloxacin or ofloxacin we are giving monthly once regimen, so this type of complication, tendinitis or tendon rupture, producing disability may not be noticeable when you use monthly once dose moxifloxacin.
All right. People also wanted to ask the efficacy of rifampicin 600 milligram preventive to contacts now used in program.
Yeah, this now the program, the single dose reformation SDR has been introduced. WHO also recommended it, single dose regimen, and it has a lot of controversies because again we are giving monotherapy, single dose, how much it will be effective,
Right.
single dose, how much it will kill the bacteria, whatever bacteria there. Now that's to replace the SDR. Now the latest multi-drug chemoprophylaxis trial is already started in 3 countries, India, Brazil, and Indonesia. The combination of reformation, clarithromycin combination, because both clarithro and reformation has very good drugs. They are giving monthly once for 3 months. This trial is going on in 3 countries. I am one of the investigator and member of that research group for 3 countries. We have to wait for 3 to 4 years to find the result of the efficacy of this 2 drugs combination monthly once for 3 months to all the close contacts of index cases. In place of single dose reformation, I think this combination will be better efficacious because they have found the very near close contacts when you give SDR, the efficacy rate is only 30%.
And Shreya wanted to ask, in DDS, do we use rifampicin every day?
When among the outer contacts, the efficacy is 70%. Once every 14 days, and reformation is highly bactericidal, it doesn't mean it should be always given monthly once. There is no need, it's just wastage of drug when you give daily reformation.
And Snehashish wanted to ask, do you recommend second line therapy for younger patients given the pigmentary side effects of MDT?
Pigmentation, only clofazimine produces pigmentation, and as I told you, is always temporary. After stopping the therapy, clofazimine disappears in 6 months to 3 years time. And in the last trial in the UMDT, it has been seen it is very much acceptable among the children also, because we have very less regimen, we have very few drugs to treat young people. If we leave clofazimine, we cannot give moxifloxacin, we cannot give ofloxacin, we cannot give minocycline among all the drugs. So clofazimine is left behind only. So probably we have to counsel the parents of the children to accept the clofazimine, because we have to tell them the pigmentation is always temporary. After stopping the therapy, this pigmentation disappears.
Neha wanted to ask to highlight any newer treatment for type 1 reaction. Do you suggest some?
Type 1 reaction, still the best is oral steroid. Oral steroid is the best regimen. Only thing, the management of steroid dosing schedule is very important. When you're starting type 1 reaction, we have to give very sorry, high dose of steroid, at least 1 milligram per kg by weight initially, and maintenance therapy we have to continue 20 to 30 milligram steroid for a longer period to prevent the relapse of the type 1 reaction. Most important is type 1 reaction relapse very easily. Once you stop steroid, it relapses very often. So the maintenance therapy, 15 to 20 milligrams steroid, you have to give for a long time. Even after stopping MDT, patient has to continue low dose of steroid to prevent late reversal reaction.
And Shreya wanted to ask that according to recent guidelines, do we give clofazimine in paucibacillary cases also?
Yeah, this is exactly UMDT. UMDT combination of all the 3 drugs can be given in paucibacillary for 6 months, and this is good that it's better to give more than 2 drugs, because because you cannot establish drug resistance in pursuous leprosy, because the patient might have infected by the primary resistant M. leprae. So if you give 3 drugs regimen, it's always good. And another advantage of giving 3 drugs, the misdiagnosis of multivascular many times, because we are not doing bacteriological study. We just counting the number of patches. We are classifying the leprosy multivascular or passivascular. In the wrong diagnosis case, also 3 drugs will help. At least the patient is getting 6 months of 3 drugs, even though BI is 1 plus or 2 plus, it will take care of. These 3 drugs combination for 6 months will take care of the BI positive cases also.
And Dr. Ravi Shankar wanted to ask, what are the regional centers for the resistance studies?
Yeah, there are 5 centers. One is the Delhi, Delhi Sadra, and the one center that is
Voice problem.
and one is in Agra, Jalma. Yeah, there are 4 to 5 centers available. You can see the website. You can get the address. Delhi, we sent to Sadra, ILA. They're very good. We even we all from medical colleges of Delhi. We send the skin biopsy to them to get the result, and they are always ready to accept our biopsy material and send the report within 7 days without charging any money, neither from the patient nor from the organization, because they get money from NLEP and WHO. They are the WHO centers for do the drug resistance study. But Sengupta is there in charge. You can contact them in Sadra.
Yogita Mohale wanted to ask some information regarding steroids in leprosy. Probably we have discussed the whole issues, but do you want to give anything special regarding the use of steroids?
Yeah, this is very important, and Dr. Sethi has published a very good article, use of steroid. Does the addition of steroid for reaction or for neuritis, really does it hamper the therapy? It has been seen very interestingly, when you give steroid, it does not help, it does not hamper the bacteriological kill when the patient is on multi-drug therapy. Very, very important. Directly, steroid doesn't have any role preventing the bacterial kill when the patient is under multi-drug therapy. So you can give steroid.
Well,
But at the same time, there is another study. Yeah, another study. Steroid, prophylactic steroid, when it is given in leprosy patient, it does not prevent development of nerve damage or reaction. That's another. So it doesn't help prophylactically. When there is reaction, when there is neuritis, then you give steroid.
well, Neha wanted to ask in this Corona COVID area, should there be some changes in the treatment of lepra reactions?
No, I don't think only you have to reduce the dose of steroid only. You cannot give very high dose of steroid. You have to give 30-40 milligram steroid instead of giving more than 60 milligram steroid. That's the only protocol we received to reduce the dose of steroid when if the patient is positive for COVID-19.
Kanchan Kumawat, she also raised a similar kind of question. Probably she must have received the answer that we have to use the lesser dose of steroids in this COVID area. So that covers most of the queries which have been raised, and it was an excellent talk, except for the few hiccups in the internet of that nobody can handle that. It is, but everyone enjoyed, and people are stick to the internet. There are many
Sir,
senior
sir,
people
sir,
also.
excuse me, sir. Can I ask one more question, sir, please?
Yes, please.
Sir, actually, in type 2 leper reaction, in anal cases, we give 300 milligram of clofazimine when it is resistant to steroid. But the same time, we are giving 50 milligram of clofazimine in daily dose also. So what is the requirement of again giving that 50 milligram, because it is already covered with clofazimine of 300 milligram?
Yeah, because we give clofazimine higher doses. Initial first 1 month we give 300 milligram, then reduce to 200 milligram next month, then reduce to 100 milligram next month. And then we have to maintenance with 100 milligram clofazimine is very essential to prevent the recurrence of type 2 reaction. So for type 2
No,
reaction,
sorry,
we
sir.
have all three drugs: steroid. Yeah.
You first identify yourself. That's how you please. That will be good.
Excuse me, sir. I am Dr. Mahanti. I am the Director of State Institute of Health and Family Welfare, Odisha, sir.
Very good, great. Thank you very much for coming and attending over here. Dr. Hemant must be knowing.
Yeah.
Dr. Hemant,
Okay,
you.
please.
Yeah, I know, sir.
Please.
I had a good experience for 10 years in working in leprosy field of leprosy, sir. I have visited Jalma Institute also.
Well,
I have
Great.
attended the
so nice.
international conferences, etc.
Great. So nice to.
Sir, my question, I want to clarify it, sir. We are giving 50 milligram in a daily dose also, and simultaneously we are giving 300 milligram or 200, whatever may be the dose of clofazimine for addressing that reaction. So, is that 50 milligram again in addition required?
Yeah.
Actually, when we are giving 300 milligram or 200 milligram daily?
Yeah, that's a good question. For reaction, clofazimine needs higher dose because of to get the proper anti-inflammatory effect of clofazimine, high dose is required. The accumulation is giving 50 milligram daily or 300 milligram once monthly. The quantum of the drug is not enough to have its anti-inflammatory effect. Therefore, we give higher dose, but we have to be very careful. Higher dose should not be given for more than 3 to 6 months because it gets accumulated as the crystals in the intestinal mucosa and producing lot of abdominal pain and diarrhea and severe abdominal pain. So very carefully, clofazimine has to be given, should not be given more than 3 to 6 months, the higher dose.
That's right, sir. But during the administration of that 300 milligram of clofazimine, is there any necessity of again giving that 50 milligram daily dose? Because it is already covered with.
Yeah, the whole idea of giving 300 milligram of clofazimine is that, the compliance. Many times the patient does not take the drugs daily. That's why when you give monthly 300 milligram of clofazimine, it gets accumulated. But that accumulated clofazimine is not sufficient enough to take care of the reaction part.
Okay, thank you, sir.
That's why we're giving 300 milligram almost daily, first 1 month, to just build up the quantum of clofazimine to have the optimum anti-inflammatory effect of the clofazimine. In fact, we do not know exactly how this anti-inflammatory action of clofazimine, but it works well.
Thank you so much, sir. Thank you.
Yeah.
Sir.
Well, thank you very much, Dr. Hemant. It was a very nice interactive session.
Thank you so much.
And all postgraduates must have enjoyed for that. Any other person wants to have some comment or question other than the internet quality of at places? I could see many people, and if there are no comments or questions, then we can call it a day. And the next, let me tell the all postgraduates that next week's program is ready. Yes, any question?
Hello.
Hello, I am Dr. Sujata.
Yes.
Sir, in case of dapsone sensitivity, what is the line of treatment of treatment in leprosy treatment?
Yeah, that's I already have a slide. Dapsone, as you know, it's a bacteriostatic drug. It's very weakly bactericidal. You can omit dapsone. You can give combination of only clofazimine and rifamycin in case of multiple leprosy. for 12 months, or you can extend to 24 months. And in possible slurry, you can give the combination of clofazimine and rifampicin instead of you can stop Dapsone.
Okay, thank you, sir.
All right. So the next week full program is ready, and we just watch on these WhatsApp groups. We have got very interesting lectures in the next week also. So thank you very much, and thank you, Dr. Hemant, once again, and thanks all who has come and participated over here. So I'm just
Thank you.
ending the meeting. Thank you. Thanks a lot.
Thank you so much. Thank you. Thank you.
Good night.
Good night. Good night.